Okay, you can go ahead.
Right, good afternoon, everybody. Welcome to this week's Gecko session on upper endoscopy. My name is Matt Scriba. I work at Groote Hospital, University of Cape Town. And I just want to welcome you all and say that G-Echo is hosted by the Gastro Foundation in association with Project Echo, University of New Mexico. And these sessions are held weekly on a Wednesday. The chat will be open to questions. I'll try and keep that open, keep my eye on that. And today's topic, I'm just going to share my screen here, is all about achalasia. Let me just have a look. Just wait for that to come up. Okay. All right. Okay, so let me just make sure. I'm going to try and keep the chat box open. I'm just going to bring that up. But today's topic is all about achalasia. I'm going to start off by giving a brief overview of just some of the basics of achalasia, how we diagnose it, how we go about specifically making the diagnosis on manometry, which is kind of the focus of these talks. And then I'm going to go through 3 cases today to highlight some more difficult diagnostic challenges we sometimes face with achalasia. I've previously done achalasia cases in some of these sessions, so today we are slightly more, shall we say, advanced cases of achalasia. So we know that achalasia is supposed to be actually rather uncommon, arguably rare, with only about 1 to 2 new cases per 100,000 every year. We have a particular conglomeration of patients here in our setting because we're a big referral center. So we seem to see a lot more achalasia, but I think we're very biased in that regard, but it is supposed to be rare. There's no difference between male and female presentation in terms of incidence. And the peak age tends to be around 30, 40 years old, although we know that we can see it in children, we can see it in very old people. And essentially, it's an idiopathic and incurable disease. So that sounds very dramatic. And we also say that all our treatment is aimed to be palliative, which also sounds quite dramatic. But remember, this is not a cancer. And we always tell our patients that although we can't cure it, it's not usually a disease that's going to kill you. It isn't like a cancer. The underlying pathophysiology is essentially not that well understood. We call it idiopathic, but we think there's definitely an immune basis to it. And at the moment, molecular mimicry is probably the mechanism that's most likely to blame. And viral infections such as herpes simplex are the predominant underlying mechanism that's been proposed. And we know that certainly individuals have to have a genetic predisposition for this. That's why it doesn't occur with everybody that gets herpes simplex infection. And the underlying problem is that through an immune-mediated response, we land up destroying the Auerbach plexus or the mesenteric plexus nerves. And for that reason, the patients then have an esophagus that's no longer innervated, especially to the circular smooth muscles. Now, we always have to consider when we see a case that looks like achalasia, that there are a whole bunch of other things that look like achalasia that aren't true idiopathic achalasia. So we have, that should say iatrogenic at the top, not idiopathic. One of the most common reasons is that we as surgeons operate these patients for reflux. We can make it too tight and cause them to have something that looks like achalasia. Similarly, paraesophageal hernias can sometimes do that. Cancer is always the typical pseudoachalasia that's spoken about is a cardiac cancer that lands up leading to a pseudoachalasia type picture. We also get paraneoplastic conditions, and small cell lung cancer is the most likely candidate for this. Eosinophilic esophagitis can look like achalasia. It's always something we should exclude on esophageal biopsies. Chagas disease is always mentioned. It's not something we have here. That happens in South America. And then opioids. Now, they don't cause the typical picture of achalasia that we usually see, which is complete aperistalsis, but they do cause failure of the lower esophageal sphincter to relax and can cause spasm. So they can cause things that look like a type 3 achalasia. A little bit more about that later. So when these patients present, they usually have dysphagia, but sometimes we struggle to elicit that information from them. And often they present more like patients with acid reflux. They get regurgitation, heartburn, which is actually usually chest pain, but it's misinterpreted as heartburn, or can come from stasis, and that can cause pain that feels like heartburn. And the cardinal other symptom of achalasia is weight loss. There's usually some weight loss. If it's very rapid and a lot, we have to consider a case of pseudoachalasia. And most patients suffer with these symptoms for at least 2 to 4 years before they get the diagnosis of achalasia. This is typically how long they wait. We use the ECOT score, which reminds us which of the symptoms we should ask for: dysphagia, regurg, chest pain, and weight loss. And it's graded according to how often these occur, and the patient gets a score out of 12. We use this pre-therapy, which can be quite high, and then we see how well they do after we do an intervention, for example, hilismartomy, and we always aim to get the ECOT score to 3 or less after we've given the patient intervention. Now, in terms of diagnosis, other than clinical, which is not very reliable, the first step is usually to do an endoscopy for these patients. And this is a scope that was initially reported as normal. You can see it was done by a junior endoscopist, but you can see that this esophagus does look a bit dilated. There's a lot of saliva here. And although the mucosa is grossly normal, when we come down to the oji junction, it's quite tight and difficult to negotiate. And the classic reported finding one can see with achalasia is that you have this tight oji junction, but if you persist and wait with your scope, you eventually go through with a classic pop like that, and we're in the stomach. So this is the finding of a patient perhaps with slightly earlier achalasia, although this esophagus was already quite dilated. In some patients, if you wait long enough, it can look like you in the stomach. So here's a scope in a patient with end-stage achalasia, a sigmoid esophagus. You can see there's a lot of fluid and food lying around. And in a similar patient here, the wall of the esophagus is usually coated, and people call this fungal infection. They think it's candidiasis, but actually it's just stasis, and they may not need something like fluconazole. And you can see that there's just a pool, a puddle of fluid and food lying in the esophagus. This is not the stomach, and often there's some confusion about this, and people get a bit lost. If you persist and you wait a bit, if you're lucky, you can come down and find the oji junction, which hopefully will reveal itself shortly here. And eventually one can hopefully get through into the stomach. Sometimes that isn't possible. Okay, so these are the findings on the scope. I would like to say that in early achalasia, the scope can look completely normal. When we do investigate these patients, usually if they've had a scope and it hasn't given us the answer, the next step is to do a barium swallow. And you can see on your left is what we typically describe as achalasia. So this is a dilated esophagus here. And remember, on a barium swallow, we compare the diameter of the esophagus to the diameter of the vertebral body on the AP view, which this is more of a lateral view. And it should never be more than 50% of that. So a typical esophagus is about 2 centimeters in diameter, and a typical vertebral body is about 4 centimeters in diameter. And it should never be bigger than that. So in this case, this is quite dilated. This is probably the whole length of the diameter. And we can see this typical tapered appearance, which we call either a bird's beak. In this case, it almost looks like rat tail here. There's a thin bit of contrast there. There is contrast holdup and very poor drainage, and there's often a contrast air level. And if one looks carefully, there's often what looks like foamy material at the top of the swallow, and this is usually from saliva, or in severe cases where the food has been in the esophagus so long that they actually end up having fermentation, and it forms bubbles. On the left, on your right here, is a patient with achalasia, but this is a more spastic type of achalasia, something like type 3, but early on it can look like this as well, and you get much more vigorous tertiary contractions that almost looks like corkscrewing or what we call beading. And this is usually more in keeping with spasm, so either distal esophageal spasm, which is not achalasia, or a type 3 achalasia, which is a very rare subtype of achalasia. Now, both, unfortunately, swallow and barium swallow and scope doesn't confirm the diagnosis. We actually need a manometry, and this is, of course, the problem because this is not readily available everywhere. But this is the gold standard on how we make the diagnosis. And we use this algorithm from the Chicago 4 classification to make the diagnosis of achalasia. And this is probably the most important table from that document. And essentially, one starts at the top here by doing 10 wet swallows during manometry, and we then decide whether the median IRP is high or not. If it's high, we move to this side of the screen to the left, and here we decide, are we dealing with one of the 3 types of achalasia, or otherwise, are we dealing with an Urge junction outflow obstruction? If we're not dealing with any of that, we go to the right here, and we're dealing with one of 4 major motility disorders or disorders of peristalsis. Otherwise, we might just be dealing with a patient that's normal. Now, this group down here in the bottom left are the Urge junction outflow obstruction group. Now, this is a big heterogeneous group, and some of these patients may well also be achalasia. They just haven't quite met the criteria, but some of them are not. And therefore, these patients often require further testing, such as a time barium esophagogram or endoflip if one has that available, which I think most of us don't. So let's just go through the typical findings on manometry of the 3 types of achalasia. This is the type 1, or so-called classic achalasia. And this is essentially what achalasia looks like when you leave it for long enough. You can see that the cardinal problem is that you have failure of relaxation of the lower esophageal sphincter. So we measure here, this little box, I'll show you just now, is called the integrated relaxation pressure, and is basically a measure of how low or how much the lower esophageal sphincter relaxes when we swallow. And the software will take this 10 seconds of pressure and record the 4 lowest seconds of pressure. And in achalasia, the average, the median of 10 swallows should be raised, should be above your reference range of normal. Now, what happens above this in the peristaltic body determines what type of achalasia we are dealing with. And here you can see in this one, there's 0 peristalsis going on. This change in pressure you see here is from the patient breathing. Those are breathing artifacts. That is not peristalsis. So this is a complete absent contractility, and one needs to see that on all the swallows to call it a type 1. Type 2 is slightly different and is probably erroneously named because type 2 is actually, we know now, an earlier form of type 1. So if you catch achalasia earlier on, some of the swallows will look like this. Now, we only need 2 of the 10, only 20% to look like this. And what we have here again is failure of relaxation of the lower esophageal sphincter, but we also have these vertical bars of pressure that we call pan-esophageal pressurization. And in some patients, you get this, what we call shortening of the esophagus. So this is due to longitudinal muscle action that is still retained, and there's still some longitudinal muscle activity in the earlier forms of the disease. Now, in our setting, this is less common than type 1, and that's just a reflection that we are getting these patients later on in the disease. And if we were to diagnose them earlier, we would be diagnosing more type 2 achalasias. Type 3 is a completely different animal altogether, and some people suggest that maybe this is a different disease. But essentially, in these patients, we similarly, like in type 1 and 2, have failure of relaxation. But what happens above that is you get these strange abnormal pressurizations, and at least 2 of them have to have spasm. And what spasm means is that the peristalsis occurs too quickly. So the time period from when you start your swallow, which is this point here, to this mark here should normally be more than 4.5 seconds. We call that the distal latency. And in type 3, at least 2 of the 10 swallows have a distal latency that's less than that. So it's too quick. That's what spasm is. And the rest of the swallows in type 3 should also not have normal peristalsis. There's failed peristalsis or abnormal peristalsis throughout. This is very rare. We only see a handful of these every now and then, and that can be tricky to diagnose. The underlying mechanism for why it looks so different is poorly understood, and probably relates to it being not so much destruction of the underlying nerves, but a neuritis, an inflammation, ongoing inflammation of the nerves. And so they just malfunction instead of not functioning at all. But I think it's a lot more complicated than that. Now, the last slide on before we get to the cases is how we actually manage these patients. And there's basically 4 big groups of management options. The first is medical. This is well described and includes the use of nitrates and calcium channel blockers. But Nobody really uses these anymore. They are not recommended in the guidelines because you need to give very high doses and the patients have terrible side effects, mainly headaches, and their efficacy is very limited. So we almost never use this anymore. Then we've got endoscopic management options, which includes endoscopic Botox injection into the OG junction or pneumatic balloon dilatation. Botox can be very useful, and we use it mainly in patients who can't go to theatre for a myotomy, or those either because they have poor performance status or we have lack of theatre access. For example, we have a long waiting list, or the patient doesn't want an operation. For example, we had a woman in her second trimester of pregnancy, and we wanted to rather wait for her to deliver, and then we went on. So we have a Botox, and then we did the myotomy postpartum. Pneumatic balloon dilatation is very well described, and we know from a seminal paper by Bookstein et al. That in the short term, in about 2-year follow-up in well-selected patients, this is equivalent to doing a surgical myotomy. But in the long term, I think surgical myotomies do perform better. Surgery, myotomies, this can either be done from the abdominal side as a laparoscopic Hillers, or can be done from the inside as a per-oral endoscopic myotomy, and I'll present a little bit about that just now when we do the first case. And then the last thing, which is often not that much spoken about, but sometimes we get patients who land up with end-stage achalasia, who've had one or more of these other procedures, but land up with this very dilated, baggy esophagus that's completely non-functional, where the lack of drainage at the LOS is no longer the only problem. They actually just have completely failed peristalsis and a sump effect, usually if the esophagus is quite sigmoid shaped. And in these cases, doing something like a repeat myotomy doesn't really help the patient. And then we land up doing other things, of which an esophagectomy is probably the most common thing we do. Things like a per-oral endoscopic plication is described. We've never done that here. It's where you basically make the esophagus smaller by endoscopically suturing the esophagus. I think at this point in time is certainly not part of any standard of care guidelines. Okay, so that's enough about achalasia in general, and we're going to go through some cases now. The first case is someone that came to us recently in the unit. This is a few years ago, a 35-year-old female who was referred because she was considered for a Nissen fundoplication. So she was thought to have reflux, and she was already almost lined up for the operation because she had very typical symptoms of what sounded like reflux: terrible heartburn, chest pain, already for 2 years. She had lost a bit of weight. She did have dysphagia, but it wasn't a predominant symptom she seemed to complain of. And she's otherwise had no comorbidities and previously was the optimal surgical candidate. And on scope had some esophagitis. This wasn't really quantified, and there was a hiatus hernia present. So all of these do sound like reflux. And fortunately, the surgeon went on to do a barium swallow for her, which I'm going to run now. Sorry, 1 second. There it goes. And what we can see on the swallow is that if one looks quickly, the esophagus is not massively dilated or significantly dilated. The OG junction seems to be reasonably open, although the shape of the esophagus is a bit strange, and there are some tertiary contractions. Let me see if I can play that again. Okay, so there are some abnormal peristaltic shapes here, but overall, it certainly doesn't scream that this is achalasia. But this is the point. It can look like this in early achalasia, because we went on then to do manometry for her, and 5 of her 10 swallows looked like this. We had an increased IRP here, it's 22. With the old water perfuse system, our reference range is 18, so this is above that, and the median IRP was a good 24. And here we can see beautiful panesophageal pressurizations with esophageal shortening. And so what we had here was a patient with type 2 achalasia. She had early achalasia and not reflux. Unfortunately, did not go on to have a Nissen fundoplication, which is arguably the opposite of what is good for achalasia, and she went on to have a Hillers myotomy. Case number 2 is a little bit more complicated. Here we've got a person who did go on to have anti-reflux surgery and possibly or probably actually had achalasia. So she's 56 years old. She's a very high flying individual. She works as a CEO of a local company, And this all started in 2018, where she was admitted with a pneumonia that was thought to possibly an aspiration pneumonia requiring oxygen. And at this time was found to have a hiatus hernia on an investigation we don't have access to. She unfortunately developed breast cancer the following year and required a double mastectomy. Fortunately, this was curative. She's now in remission. And at this point started having what she thought was reflux. Acid pushing up into her mouth, burning in the chest, and most importantly, recurrent aspiration episodes. Now, I think it's very important that true gastroesophageal reflux rarely causes proper aspiration, but failure to empty your esophagus does. It's much more a risk for aspiration. So she had these recurrent aspiration pneumonias, and I think this should be a red flag that maybe this isn't reflux, but rather a drainage, an esophageal drainage problem. She's got a long past medical history, hypothyroidism, rosacea. She's on some treatment for attention deficit disorder. She's taking a GLP-1 agonist, and I think throughout the world we will see more and more of this. So she was slightly obese and had already lost some 12 kilograms and was previously on an antidepressant. Importantly, she does not take any opioids. Surgical history was also quite extensive. She'd had a previous Caesar twice. Her appendix was taken out 26 years ago. And after the mastectomy and the anti-reflux surgery, which was done in 2021, she landed up needing her gallbladder removed for pancreatitis, and then had an incisional hernia repair with quite a big mesh in 2025. So her upper abdomen was not the most hospitable to enter should she require repeat surgery. Now, here is a swallow of what things looked like before her operation. And this is before she had anything done. And what we can see here is a dilated esophagus with a diverticulum and at times rather poor drainage through the OG junction, although sometimes it did drain well. Now, I think anybody with a diverticulum, there should be red lights going off. A diverticulum means that there's a problem with the underlying drainage. This swallow we're seeing here now is after the Nissen that she had, or the anti-reflux surgery. We weren't sure that it was a Nissen or a partial. And what you can see is that it's a very dilated esophagus now, and that diverticulum is actually looking a bit bigger. So I think overall what we can see here is that this is an esophagus that doesn't really look like reflux. It looks like something else, but is not confirmed. I think anybody with a diverticulum or a dilated esophagus must go on to have further imaging, ideally a manometry, and certainly shouldn't just be expedited for surgery. But then she did have the surgery, and the main indication was for these recurrent aspirations. And although the patient felt some improvement, she remained PPI dependent, but then her symptoms of dysphagia slowly got worse and worse and worse. And by the time she came to us at the beginning of this year, she had an ECOT score of 9 out of 12. We would have given her full marks if we hadn't attributed her weight loss to the GLP-1 agonist, but maybe that wasn't to blame. And the main symptoms now were dysphagia, chest pain, and foamy regurgitation, which are typical symptoms of achalasia. She would cough when she lies down and actually needed to prop herself up on 5 pillows at night when she slept. Otherwise, she would wake up coughing and feeling like she's aspirating. She had a scope done by a gastroenterologist in November, just before she came to us. And this was actually suggestive of achalasia with a markedly dilated esophagus with the diverticulum noted, quite a tight OG junction, and there was possibly a concern of a slipped fundoplication. I actually have some pictures of that. So here on the top left, you can see an esophagus that does look a bit dilated. There was quite a lot of saliva. Here at the bottom, you can see this outpouching is the small diverticulum. Okay, sometimes difficult to see on a scope if it's not a big diverticulum. And these two pictures of the OG junction, which looks reasonably tight, but the scope could be negotiated through there eventually. Here is a retroflex view of what the wrap looked like. This was important for us later because we had to decide whether we think this is a full wrap or a partial wrap. Difficult to decide, but based on some of these pictures, we think it was probably a partial wrap, which was good. But we can see that there's certainly not a big recurrence of the hernia. The OG junction looks, if anything, a bit too tight. So she came to us and we opted because she'd had her last swallow a good 5 years ago. We repeated her swallow now 5 years later, and things, as you can see here, had certainly progressed. So here you can see, here's the diverticulum, and you can see this esophagus has become more and more sigmoid-like and is significantly dilated. The other thing that's striking here is that there's very, very little contrast going through into the stomach. So this is a very obstructed, unhappy esophagus. You can see it a bit more clearly here, and there's a clear holdup of contrast with a contrast air level. Okay, so we're definitely now dealing with an esophagus that's very unhappy. So she came to us, and I performed a high resolution manometry for her. And what we found, so if we look on this image, we can see a non-relaxing LOS with a high IRP. The IRP here is 24. Anything above 22 with our solid state catheter is high. The other thing that we can see is that there is no peristalsis above it. Okay, and almost all her swallows looked like this. 9 of the 10 looked like this. One of them looked like this, which was quite interesting. So here we've got an LOS that where we measure here does look at like it's relaxing a bit, but here it goes almost into this very hypercontractile type scenario. And we can see that this meets the criteria for panesophageal pressurization. And there's marked shortening of this esophagus. So we can see the LOS is at this level, and it's jumped up to there, and even the cricopharyngeus has dropped down. So this esophagus has shortened by a good 5-6 centimeters. Okay. Now, when we sat her upright, we also got to see this sort of a pattern. Okay, so here you can see the LOS is not relaxing, pressure is 36. There is shortening here, and this looks like it wants to be a panesophageal pressurization. But importantly, if we follow the guidelines, we know that in order to call it that, the pressure has to be more than 30 millimeters of mercury from the top to the bottom. And the software automatically puts a black line around any pressure that's above 30. So this is not continuous all the way. So what we have here is probably a remnant of a panesophageal pressurization. And had we done the manometry maybe a year ago, perhaps this would have been a panesophageal pressurization. And here on the multiple rapid swallow, we see a similar thing. And similarly, on the rapid drink challenge, which is a provocation test we do to get the LOS to relax maximally, there is some relaxation, but it's not enough. Okay, and the pressure here is 14, and the upright position we want it to be 15 or less. So it is that, but it is still on the upper limit of normal, and certainly isn't normal. So overall, the median IRP findings were 34, which is very high, with 100% failed peristalsis, and that one swallow which showed a panesophageal pressurization. So we had 1 out of 10. So we can't call this, if this was purely achalasia, we would call this a type 1, not a type 2. But because she's at prior anti-reflux surgery, we can't technically call this an achalasia. We have to call it an OG junction outflow obstruction with absent contractility. Now, at this point in time, there was quite a long differential diagnosis. So what are we really dealing here? We're dealing with something that looks like achalasia, but is it really achalasia? Is it maybe a pseudo-achalasia? Are we dealing with post-surgical changes? Did she actually have a reasonably normal esophagus beforehand, and they've just made things too tight, or there's been fibrosis, and that's why the LOS is not relaxing, and over time, the esophagus somewhat burns out, and the peristalsis goes away. We have to think in this case, because she's had breast cancer, is this maybe a paraneoplastic syndrome? And she actually has recurrence. Fortunately, she did have a CT scan, and she had review of her previous mastectomy site, so she didn't have any evidence of recurrence. We thought that less likely. Is this perhaps a primary achalasia all along, and that she never had reflux? And this, I think, is the most likely diagnosis in this case. We always have to think of eosinophilic esophagitis and opioids. She doesn't use opioids, and opioids don't really cause a picture that looks like a type 1. I want to show you with the last case what opioids can do. And then the last question was, well, does the presence of a GLP-1 agonist result in any specific changes? We know that GLP-1 agonists cause significant gastroparesis and cause the stomach to not have very good motility at all. Does the same apply to the esophagus? And actually, there's very little written on this. There's certainly no guidelines or major systematic reviews on this or anything like that. There are some case series that show that there is a change to motility, but I think at this point in time, there's not enough evidence to say that her GLP-1 was causing these changes, and we certainly couldn't say that this is why she had this. So as it stood, we discussed this as a team, and we came up that most likely we think that this was probably an achalasia all along. And we based that on the fact that she had such an abnormal barium swallow before her surgery, which was already markedly dilated. There was a diverticulum, and the peristalsis did not look normal. She unfortunately didn't have a manometry before her surgery, but we think in this case we were probably dealing with an achalasia. And therefore, what she ideally would need is us to take everything down in terms of the wrap and the crural closure and do a myotomy for her. But her abdomen was not very hospitable, and she wasn't a great candidate for repeat surgery. So we then decided, well, is this a partial wrap or a full wrap? If it's a partial wrap, we might not need to take it down, because we often, when we do a Hiller's myotomy, do a partial wrap in any case. And in the end, we made the decision in discussion with her that we would stay out of the abdomen and do a per-oral endoscopic myotomy for her and leave the wrap and the abdominal part as is. And this was quite a difficult poem technically, because the esophagus was quite tortuous and very dilated with the diverticulum. And I just want to show you, I don't have pictures of her poem specifically, but just briefly go through, for those of you that might not have seen a poem before, what this is all about and how we do it in our unit. So Professor Chinnery, the head of our unit, does the poems, and it basically is a procedure that you have to do under general anesthetic. It's not an outpatient endoscopic procedure. It's a proper operation, so to say. The patient needs to be paralyzed in theater under a general anesthetic. And the procedure involves making a submucosal tunnel by first opening the mucosa with a needle knife or an endoscopic knife. We usually use a triangle tip knife. Sorry, not a needle knife, a triangle tip knife. And we then make a submucosal tunnel between the mucosa and the muscle layer all the way down to the OG junction and across into the stomach. And you can do this on the right side of the esophagus, the patient's right side, or posteriorly. We tend to do it on the right. And then the muscles are divided. And you can choose to only take the circular muscles. That's the most important, but often the longitudinal muscles are divided as well. And this is extended all the way down. And then the last thing to do is to close your mucosal entry point with some clips. So here you can see the first part. We put a cap on the scope, the mucosa at the site. So we choose the site where to enter, usually about 12 centimeters up from the OG junction. We inject and lift with a combination of methylene blue and adrenaline. And then one makes an incision through the mucosa using an endoscopic knife. One then enters this tunnel, and this is what it looks like when we make the submucosal tunnel. So on your left is the mucosa, and on the right are the muscle fibers, the circular muscle fibers. And because the cap stretches it, you land up with this areola type connective tissue that is then divided using coagulation with this, as you can see, is the triangle tip knife here. And this tunnel is then extended all the way down to the bottom. And what we then do is we divide the muscle. So here the myotomy is being done. We start at the top, about 2 centimeters below where we entered the mucosa. And here you can see how the circular muscles are divided. This is actually dividing the circular and longitudinal muscles, and one is actually then technically in the mediastinum. So here's the muscle being divided. This is the mucosa above it, and one has to obviously be careful not to burn all the way through there, then you know, with a perforation. Then at the end, you can see this is the submucosal tunnel. Here's the myotomy completed. These are the split muscle fibers. The mucosa is on the left here. And we come up the entire length of this tunnel. It's quite a beautiful thing to see. And then at the end, you pop out now, and we're in the true lumen of the esophagus, and we go down and make sure we haven't made a hole anywhere, a mucosal breach, and that we have gone right across the OG junction into the stomach. And you can really see that there was better drainage there. The last thing to do is to close the mucosal defect, and we use quite a few endoscopic clips, about 6 to 8 usually, and you can see how this is performed here. You need an assistant that knows how to operate the clips. It's ideal to use clips that can rotate, and you have to ensure that you get good seal. It's basically like suturing up the mucosa, and make sure that you go all the way to the top, and you land up usually with something that looks like this. Okay, and so she had this done, and this is the post-op swallow. As you see there, it's running. And what you can see here is that there's significantly improved drainage compared to the pre-op picture, and the esophagus looks much smaller already. Although it's quite tortuous, you can see the diameter is much smaller than what we had pre-op, and we consider this a success. And she certainly had improved ability to swallow and is currently doing well. She's only a few weeks out, but she's currently doing quite well. Now, case number 3, the last case, and then we can answer some questions. This is a 61-year-old patient that came to us referred by our medical gastroenterologist here at Groote Hospital with the concern of reflux. And she was referred for 24-hour pH testing. She had symptoms of heartburn with regurgitation and what she described as chest heaviness. She had some response to PPI, but only to certain brand PPI. Now, that's always for me somewhat of a concern, because we know that all PPIs, if they're used correctly, work pretty much the same, and the brand usually doesn't make a difference. She did report some dysphagia, but again, this wasn't a predominant symptom of hers. And she also reported painful shoulders, right upper quadrant pain, and bloating. So there was some concern of other symptoms that were unrelated, possibly functional symptoms. Now, importantly, she was well known to our medical gastroenterologist because she's known with Crohn's disease, and she had predominant perianal disease and has needed about 70 prior perianal surgeries and multiple laparotomies as well. And because of this, mainly due to failure of the anal sphincter complex, landed up with chronic diarrhea, not so much incontinence, but ongoing chronic diarrhea. And she would take very high doses of loperamide every day and codeine. Now, importantly, loperamide is an opioid agonist, and it can have similar effects as opioids on the esophagus, and wasn't on any specific other medical treatment for her Crohn's at the time. She's also hypertensive, hypothyroidism, and again was on fluoxetine for depression. She was obese and had some other things. She smoked and was being seen by our HPB colleagues for gallstones. So there was quite a lot going on. Endoscopy was essentially reported as normal. There was nothing much seen, and she went on to have a barium swallow. Let's see if that runs. And what's striking here is that it looks quite normal. So this is not a significantly dilated esophagus. It drains quite nicely, and there's no real residual contrast in the esophagus, a little bit there, but the OG junction seems nicely patent. So this is not really suggestive of much at all. So at this point in time, we didn't really have the answer, and the concern is, well, are we dealing with reflux? So she came to me for a 24-hour pH test, and I always do a manometry first. And what we found on this manometry was a little bit surprising. We found a low esophageal sphincter with a high IRP, so failure to relax, very abnormal looking peristalsis with a distal latency of less than 4.5 seconds. So this is in keeping with spasm. And you can see that there are strange pressurizations that are lying sort of under and before the peristaltic wave. And this meets the criteria for compartmentalized pressurization. And this is a sign that the low esophageal sphincter is not opening nicely, and there is a concern for obstruction. And here we have a similar finding, sometimes quite marked. You can see marked intrabolus pressurizations here. And again, we had distal latency that was quite low. So overall, this is the multiple rapid swallow. And here we actually have panesophageal pressurization, as you can see here. Another indication that there's a problem with pressurization, and it's reflective of the failure of relaxation of the low esophageal sphincter. And the rapid drink challenge did not really show that the IRP was dropping significantly low enough. So again, there's panesophageal pressurization here. So the conclusion of this, I'm just going to skip ahead. Sorry, just before I do that, this is one of the cookie swallows. We also give the patients cookie to eat. And I think this is sort of the textbook picture of what a type 3 achalasia looks like. You've got a very high IRP, and you've got this clearly spastic contraction with a very low distal latency. This is a beautiful picture of what a type 3 achalasia looks like. And in fact, the result of my manometry was that she had abnormal peristalsis throughout, with raised IRP in all positions and on all provocation testing, and manometrically, this met the criteria for a type 3 achalasia. But we know that opioids can do this, and certainly we cannot call this a primary type 3 achalasia. And so in this patient, we said this was most likely opioid-induced esophageal dysfunction, which is a known specific entity. And in this patient, especially with all her prior surgeries, we certainly didn't want to go and offer her myotomy or even a POEM. And so she was referred back to the gastroenterologist to try and get her off the opioids. And this is still an ongoing process because she certainly needs the loperamide. So this is quite a tricky case. What is interesting in this patient is that her dysphagia and symptoms vary quite a lot throughout her clinical course, and at the moment are not the predominant symptom bothering her. She's got much more concern about her low abdominal symptoms. So at this point in time, there's no push for us to address this. But I think the case just shows us that sometimes things can look like achalasia and they're not, and certainly opioids can have a profound effect on the esophagus. So the last thing, I just want to show two quick images. Sometimes we see this on a manometry, and what you can see here's the upper esophageal sphincter, and here there's nothing at the bottom. There is no lower esophageal sphincter, and this is a patient where we failed to cross the lower esophageal sphincter with the manometry catheter. This is quite common, especially in a very tight achalasia or very dilated sigmoid esophagus. And in this case, we obviously can't comment on the LOS pressures. We can't then technically call it an achalasia, but you can see there's clear absent contractility. And when we have that in all of the 10 swallows and we have a clinical picture that fits with maybe a barium swallow, we can certainly be confident enough to call this a type 1 achalasia. This is a case that caught me out a bit in my earlier manometric experiences. So here you can see upper esophageal sphincter. This looks like the lower esophageal sphincter. The IRP is very high. And I thought, wow, we're dealing with an OG junction outflow obstruction. But you can see that there's very odd looking pressurization below this pressure line, and it mirrors what's above. We call this a butterfly picture. And what this is a catheter that's kinked. So it's curled and it's kinked. And at the point where it's kinked, it obviously exerts a high pressure. And you're seeing a mirror image of the peristalsis above and below. And this catheter has certainly not crossed the esophagogastric junction. So you cannot say that there is a high IRP here. And if one corrects it, we might find that this peristalsis could actually be normal. So this is certainly not a picture that we can say with certainty is achalasia. Okay, so in conclusion, unfortunately, to diagnose achalasia, we truly do require high resolution manometry. It's not present in all places. But it's also not purely, we can't just be technicians and do the manometry and then say what it is. We need to have some clinical insight. And we usually take the whole picture into account. What are the symptoms of the patient and what other investigations, including scope and contrast swallow, we've done. But even when we have the manometry, some cases can be tricky. And I think we must never, ever forget about opioids and EOE. Opioids are something we get on history, so there's no excuse for not asking the patient about it. And EOE, we should get into the habit of doing a biopsy in every esophagus we scope where there's a history of dysphagia when it looks reasonably normal. Okay, and that's about all I have to say. I'm going to go to the chat. Are there any questions? I don't see any questions in the chat. Okay, well, that's fantastic. It doesn't seem like anybody's got any questions. Wonderful. You're welcome to also unmute yourself and ask a question if there's anybody. Okay. That's great. Well, then we can end this meeting, and I'm going to just say thanks to ECHO University New Mexico and the ECHO India team. Recordings of this are available on the website, and we thank the Gastro Foundation and the sponsors today, and I think next week will be a pediatric lecture. Okay.